Hi everyone, welcome to Northernlands 2, which is pioneering and online. And this is our Open Data Saves Live session. This is the first session, and I'd like to say welcome to Ben Goldacre and Mark Farr. In a minute, they're going to talk about and tell us who they are. But before that, my name's Paul Connell, founder of ODI Leads. So I guess you can say ODI Leads is my fault. Over to you, Mark. Tell us who you are and what you're doing here.
Hi Paul, I'm the Chief Analytical Officer for East Kent Hospitals, which is a big acute trust based across that side of Kent, from Margate right across to Ashford, including Canterbury and various other things. And I'm also the Regional Chair for Analytics for Kent and Medway. I get involved in a whole range of other things with people like yourselves and Ben and the Health Foundation and others, but that's my day job.
Ben?
My name's Ben Goldacre. I trained as a doctor at Oxford and London, then trained in psychiatry at the Maudsley, trained in epidemiology, which is kind of applied medical statistics at London School of Hygiene. And then I came to Oxford 4 years ago to set up something called the Data Lab. And we're quite an odd group in the sense that we're a truly mixed team of software developers, traditional academic researchers and clinicians. And we set out to build live, interactive, data-driven tools and services, as well as traditional academic research papers. And then I guess alongside that, I also do showing off stuff. So I wrote a column in The Guardian and wrote books called Bad Science and stuff like that.
Fantastic. So odd people showing off. I feel comfortable with that. That's good. So Open Data Saves Lives, that came to be part of ODI Leads' strategy last year, and it's basically it's Mark's fault. So Mark came and spoke kindly at the Northernlands 1 conference, and he put that in my head about Open Data Saves Lives as something we could use to engage with people in the health and social care sector and take all the stuff we've been doing and apply it to the health sector. But we didn't know how important it would become in 2020. It was something we started in 2019, we started work on it. And then since the start of this year with the pandemic, we've been doing a weekly session around data, health, and what we can do to help and share. And we've all been looking on with awe and admiration at the work you've been doing at Open Safely, Ben. So tell us about it, tell us what it does, and tell us why it's so amazing.
Oh, thanks. All right, you have to promise me that we can talk about open prescribing at some point, because that is actual open data.
Yes.
Open Safely is interesting because it's the absolute opposite. It is the most closed data imaginable, and rightly so. It's individual patients' full electronic health record. So we've built a very highly secure and unprecedented electronic health records analytics platform that's running across the full primary care data pseudonymized of 40% of the population. So that's about 20-something million people. And we wanted to, in order to achieve that, we had kind of various goals. First up, we knew we couldn't do it in the traditional model of doing a large data extract and researchers downloading that onto their local hard drive and then running some Stata code or some R code in a kind of walled garden stats package. And we couldn't do that because that would be monstrously insecure, but it's also inefficient and expensive to ship 40 billion rows of data, which is what we're working across. So instead, we built a secure analytics platform inside the data center of the EHR vendors, TPP. So that's where the data already resides. And that brings a number of really important positive benefits. First of all, it's very cheap and efficient. You're not shipping 40 billion rows around the country, even down the fattest N3 pipe or post N3. It's still at the scale where you'd want to drive. Well, I mean, you're not really allowed to drive around too much at the moment, but it's at the scale of data where in peacetime, you'd stick a hard drive on the passenger seat and drive to go and get it. Secondly, it allows you access to near real-time data, which is really important in a pandemic, instead of large episodic extracts. It also brings, however, enormous security benefits. So you're already in an ISO 27001 compliant environment. You're in a place where you've got logs of everything that happens, so you can be certain that everything's safe and secure. And you're not exposed to the risks of people doing re-identification attacks on data, which is what you get with big downloaded data sets.
Yeah.
Do you think everybody understands about the risks of re-identification attacks, or shall I explain them briefly?
You've got 47 seconds to do it.
All right, so take my wife. If you want to find my wife in a GP electronic research data set, even though it's taken her name and her date of birth off, you just look for somebody who had twins in 2013, a baby in 2014, and the event codes moved from London to Oxford around about 2015. And then from publicly available information, you found my wife. Having then re-identified my wife in a pseudonymized data set, you then discover everything else that's attached to her pseudo ID, including all of, chlamydia episodes after we got married, or nocturnal enuresis, bedwetting aged 14, or any of these other things, which do not apply to my wife, to be absolutely clear. But I'm just giving you examples of, first of all, how easy it is to identify somebody, and also the catastrophe of what you could discover about them. But we also wanted to go beyond just having even a generic trusted research environment, because we thought we could do better. So the most disclosive data, the riskiest data, is the event level data, where it's like one row and it says this pseudonym ID on this date at this time had a blood pressure test and it was 140 systolic over 70 diastolic. Those kinds of single events. Now, when you're doing epidemiology research, you don't necessarily need all of that very granular detail. For example, you might want to build a data set that's one row per patient rather than one row per event. And for each patient, you might want to say, create a variable that's 1 if they've had a high blood pressure reading in the last 6 months and 0 if they've not. We didn't want to create a world in which researchers had the full power of a versatile query language against the most disclosive data. So instead, we've built a platform where researchers never have to do that, never should be able to do that, never do that. So instead, you describe your study population, and that's essentially just a very stripped down representation of the SQL query that you want to do. And then that runs against the real data to extract your true data set, and then you can run your Stata code or your R code or whatever. And there's lots of really clever fancy bits in between there. So for example, we wanted to push forward from a world in which people do electronic health records research in silos, for the most part never sharing their code lists, which is what you'd use to identify outcome variables or drug exposures or disease exposures, never sharing code. We wanted to push people towards open ways of working, but not in a kind of shaking fists kind of way, but just make it easy for people to do the right thing. So we built Open Safely in that image. And so anytime you want to run code against the platform or define a cohort, you have to do that by writing it in a GitHub repo. You can clone a template right now. And if anybody wants to at home, you can go to Open Safely's GitHub repos and you can clone that template and you can build your own study definition. Then we're also trying to bring sort of computational data science techniques into being the norm for EHR research. So, for example, you write your study definition and you don't just say, I want this outcome variable to be, have you got high blood pressure or not? You also say, I want this outcome variable to be high blood pressure, using the following code lists in the following date range to say 1 or 0. And I'm expecting the prevalence of that to be 15% of the population. We then automatically generate a simulated data set. So it's not synthetic data that respects the co-segregation of exposure and outcome variables. It's just a simulated data set randomly generated. So then you can develop your Stata or R code and it will check on GitHub that it passes tests. Then you push it to run on the real data, and then you get your summary results out, and then somebody manually, well, 2 people manually look at them to make sure they're not disclosive, and then they get released out so that the rest of the team can take a look. And it's all built in a glorious giant collaboration, and I cannot tell you how much fun it's been. it's bordering on a love affair between our teams, actually. And it feels to me like a massively missed opportunity to get EHR software developers working closely with EHR researchers. It's a sort of real no-brainer. And actually, I feel like it's, as with a lot of things during COVID, and I hope we sort of can talk about this in more detail later, it's been great to see the pace picking up and some unhelpful barriers cautiously and thoughtfully worked around during the period of COVID.
So Mark, you run data at a massive hospital. What's it been like in a massive hospital dealing with data and COVID?
I mean, I thought like you, it was sort of be beholden on me to do kind of first line research. So I went to a place in Austria where everybody caught COVID, and then but the weird thing for us is that, because a lot of people say to us, well, how do you cope with situations like this? Well, hospitals, they sort of do that a lot. You know, we're ready for planes to fly into bridges and, you know, natural disasters and oil spills and chemical issues and all this. So we're quite good at putting up our operational control centre, producing gold command and silver command and bronze command and all those sorts of things. But it's like nothing else we've ever seen. And a lot of the issues for me, and I agree with a lot of what Ben said, and I'll give you some examples in a minute of things that I think are really positive and have kind of accelerated. But we had to receive national modelling advice and then work out really quickly that it didn't really work for us. So then had to stand up local modelling resources to build models that were more akin to us, that didn't take sort of national averages and just apply them crudely down into Kent. So we had a whole stream of modelling work that started really quickly. Now, are we going to put up a military hospital, a kind of a Nightingale for Kent, as it were, and how many ventilators would we need and where would we get them from? And it all felt really, really difficult. And, you know, we thought we were going to have hundreds and hundreds of ITU beds. And as of today, I think we've got less than 40 people in an ITU bed on a ventilator. So we converted theatres into ITUs, which we're now converting back the other way. And it's not out of any mistakes that people made. It's just it's been so new that we've had to kind of work in such an agile way with the data, particularly around the modelling. I agree with Ben that we've got some stuff done that's been really positive. For almost 2 years, I've been trying to get the NHS to agree to share data with the police to analyse intimate partner violence. I felt really strongly about this, and there was a lot of reporting through April in the Sunday papers about domestic abuse and, you know, calls to support centres and so on. And we managed to make the case that it's reasonable to link these two data sets together, done securely, done appropriately, you know, along similar but different to what Ben's done. And we got that agreement. We've got that agreement for 3 out of the 4 hospitals in Kent within a week. And I'm going to try and knock the last one over soon. And we've had some initial results back from the police, just at a kind of linking 2 files together level before we even start trying to do any sort of predictive modelling. And it looks like it's really, really powerful, the data. So getting stuff done and getting it done quickly and sensitively, I completely agree with Ben. That's been really key for us.
Yeah. And we've been talking, you know, one of the concepts is how do we now get that, and how do we write it up? So you're doing it in Kent. How does it happen in Carlisle? It just happens without us all getting involved. And it links to your point, Ben, of forcing people to be open in how they access the data, how they access your work. And that's fundamentally what Open Data Saves Lives is about. So I guess we're talking about getting people to use the web. So when you write a blog post about that, Mark, and we put the governance framework around it, and you write a little story blog and a technical blog, and we put the code on GitHub, how do we get that deployed in Carlisle next year without having to spend a load of money on consultants? Which, you know, that's the dream, really.
Yeah, I mean, we've put a lot of stuff out publicly. So all of the joint data control agreements that we've had that have been through 25 lawyers, everything that we run through the committee I chair is all publicly available. So we've set up new local data sets for COVID, not because the regulators asked us to, but because it seemed like a sensible thing to do. We've shared through your good selves data dictionaries for all of that. We've got through the webinars, we've got people kind of adopting that and, you know, giving us advice on where is the latest decent list of where care homes are, because that was something we had to look at really urgently, really quickly. And just getting UPRN data for care homes would have just been turgid and taken months and months. And we kind of got that done quite quickly. I think
Which do you think is the best, by the way, Mark? Did you get a CQC care homes list matched to UPRN?
Yes, I think that was, and again, that was through just contacts of Paul. We got to that list much quicker than we would have done historically. So that's quite useful, that published data that the CQC do.
Well, we went through geography at Open Data Saves Lives in a session, and it was it's how the UK has managed to shoot itself in the foot about geography and how the...
No, I agree. I think there's some really interesting cultural stuff in there as well. Like, for example, there's often a lot of anxiety and lack of clarity around licensing for things like geodata. And that's almost worse than just a hard yes or a hard no to a given data set. In particular, because it lets people who are being miserly off the hook because they can live in the shadows. But also it creates anxiety where, you know, you might have one individual in an organization who says, look, I've looked at the license. It's fine. We can reuse this. It's okay. Don't worry about it. And their boss, who's a generalist and legitimately across 14 different areas, just goes, oh God, I don't know, you know, you better go and get that reviewed by legal. And then reviewed by legal means it's in a huge queue, and reviewed by legal is expensive and slow and all that.
And it's so much easier to say no than yes, isn't it?
We've had all that with the IG. We could have just rolled over on the IG, on the police thing. And the thing I always say, you know, would be famous last words, but if you kind of go up into the legality of it and the ICO, it's about if you're doing a good thing or not. If you boil it down, the language as you become more actually becomes more loose. So are you doing something that is you were defending court and would help you sleep easy in your bed? So trying to address the risk of domestic abuse during lockdown feels like a good thing to do. I'm not building a mailing list for a drug company or anything. I feel really confident that that's a good thing to do. But it's really easy in law to say it's all a bit difficult actually, and we need to come up with a way of consenting every single patient before we do it. You know, we're trying to get the British Red Cross at the moment to look after some of the patients that come into our emergency department who've got quite chaotic lives, and they're definitely coming from a good place to try and do it. But I've had to push and push and push for us to do that, and we're now doing it because in law you kind of drift into did we consent them? Were they able to consent well enough for us to record that they'd consented enough? And I think that's part of what Open Data Saves Lives is to give a kind of robust defence against this kind of lazy privacy concern angle.
I mean, I think you do need to be, you know, good people can do bad things for the right reasons, and I think there has actually been a lot of sloppiness around IG over the years. I mean, the thing that I actually find really dispiriting is that there are a lot of projects out there which are, to my mind, monstrously insecure by design, but which have ring binders filled to overflowing with signed off paperwork saying that they are all fully legal under IG. And actually, it's really, you know, it's interesting. It cuts both ways. You can have bad IG that blocks good things. You can have bad IG also that permits very bad things. I do think that, again, there's a really interesting cultural point here, which is, first of all, during this period of turbulence, and it's not anarchy, it's flexibility. There's a lot of really good stuff being done on the hoof by people going, okay, I'm going to pick up the phone. I'm going to talk to the person in the local authority or the hospital who normally I'd have to go through 15 different layers to get to. I'm just going to go, all right, hi, is that Barbara? I've got an idea. Can we do a thing?
Yeah.
And what I'm really hoping is that I think there's a lot of enthusiasm in the air for retaining the best of the new norms that have arisen during COVID in the post-COVID era. And I think it will be really powerful if that happens. I think the other thing that I'm really hoping to see is, and this really speaks to the issues around public goods around incentivizing innovation, especially with open data and open source tools. I'm really hoping to see successful delivery, not just rewarded in terms of praise or some kind of monstrously complicated, like, oh, you're a pathfinder and now we're going to work out how to deploy it with an innovation deployment opportunity grant that costs more in-person time to ask for it than it, right? What I'm hoping we will see is people going, okay, here's a group of people who delivered something that's useful, and we're going to take the approach of GDS and the best of sort of digital innovation in the private sector and go, you resource teams, not single pieces of work. And you go, here's a bunch of people who did something really useful. Mm-hmm. Let's resource them, because fundamentally the big challenge that I think government and the health service face is you're trying to get a whole bunch of new behaviours around technical skills happening out in government, in the health service. It's really difficult to do that. You're struggling uphill against people having line managers who are generalists who don't understand the technical work that their immediate reports are engaged in, and all of that. One of the best things you can do, as well as trying to create the perfect job descriptions and the perfect formal job ladder, and you could also say, all right, we found people who are doing something useful out in the system. They're definitely delivering because they've got a proven track record of shipping outputs that worked. Now let's resource them so that they can be, number one, taken off any jobs that don't use the technical skills they have that we want to see exploding across the system. Let's resource them so that other people can go and sit next to them and watch how they work and learn from them so that they can spread. And let's resource them to either produce essentially propaganda or educational materials, either themselves or with somebody else. And actually, frankly, I think the thing we're also really overdue for is a bit of proper knowledge management. There are professions who unfortunately don't have a good name. They've got names like librarians or information scientists, but they're not putting books back on shelves. Like, there are people who've given a great deal of thought into how to curate complex technical knowledge in a commons of knowledge to help people find the information they need at the right time, to help stop good ideas getting lost and all of that.
When I was allowed to go to the pub, I used to get drunk and rant about that sort of stuff.
All I'm asking for is a coherent information architecture.
Well, do you know what? There's a thing called the web. You know? I've
heard of that. Yeah.
And if you put things on the web, people can find it. You know, and imagine if that health architecture, you know, we just said every project should have three things, which is a story blog, which describes what it is, a technical blog, which says how we did it, and then a repo with the data and code. And you link it all. And then you said, well, actually, I can then find it on the web, and then I can look it up. But
well, I mean, it links to a point that Paul and I were talking about, where one of the things we found under COVID is that we've been asked to give loads and loads of people loads of data all the time, but we never get any of it back. And if you and Ben, if you and I ran neighbouring trusts, I don't get to see your data, and you go, which would be really helpful. It'd be really helpful for me to know in Maidstone if your numbers are going up and mine are going down. Well, so we'd have to create all that ourselves.
There's also something really important, I think, Mark, around reciprocality. So if you hand over a load of data, you should expect to see the thing that it is used for coming back to you.
Yes. And not locked down again. Not locked down on an NHS England Tableau dashboard. So, I mean, joking aside, if you had a principle where every time you sent some data, a sit rep or whatever, you got everybody else's back. There's nothing identifiable on any of that, and we'll put some governance around it. But it'd be really, really powerful if I knew exactly how many people in every school in Ashford had been tested, and what our rates were as we drifted into Maidstone or we went across into. It'd be really simple to do. So we've done some really good stuff locally without being told or asked, to just link a load of our data together and to create new data sets that we're all sharing in the open, using some of Paul's tools, hopefully. But it's frustrating that you're involved in this machine of pushing data into a centre and nothing useful comes back. And even if it just went to people like you, that would be a start. But if it kind of came promptly back to us as we sent it, that'd be really, really helpful.
So Open Prescribing, which we built in my group in Oxford, is another very good example of that. So Open Prescribing is our service that lets any interested person go and see exactly what each individual GP practice is prescribing, down to the level of individual prescriptions, month by month, individual practice level. And Open Prescribing now has 135,000 unique users a year, 15 or so thousand unique users a month. It's got thousands of people subscribing to alert service that's driven off fancy statistical process control techniques under the bonnet, but which is nice and friendly and easy to use when you subscribe. And we did that very deliberately because I've worked with EHR data in the past, rich, disclosive, but pseudonymized, very detailed event level data. I wanted to start building live interactive tools and services like Open Safely, but we started with Open Prescribing without being shackled and slowed by the phenomenal cost and permissions and everything, which is legitimately around closed data. So that was the only way that we could possibly have got our group up and running and using kind of agile collaborative approaches and freely sharing code on GitHub, where we've now got 45,000 lines of code in total. Well, I think more relevantly, 1,000 issues open and closed. So working with that open data, first up, it's probably the richest health data set that's ever been shared as open data. We have published studies showing that in places where Open Prescribing is used, that prescribing improves. We've got huge numbers of examples of really important signals that we've detected on risk, quality, and cost effectiveness that simply would never have been discovered anyway. They were certainly never detected by the people employed by NHS Business Services Authority or NHS England to analyse this data. And why should they be? So that's not a criticism of those organisations, but people working behind closed doors, but also in limited numbers, obviously will never have all of the perfect answers for every possible user group, for every possible analytic idea, on every possible aspect of every possible data set. It's just ludicrous to ever imagine that that's how creative analytics could possibly work. There's also, I think, something really interesting and political here, which is around where data is and isn't disclosed. So, Mark, you work in an NHS trust, a hospital. Hospitals are quite large and powerful organisations. And there's a really interesting historical anomaly, which is that for GP level data, for practice level data, it's basically all published and shared as open data sets. Compare that with hospitals. No hospital prescribing data, well, medicines usage data, because e-prescribing hasn't really happened, but no hospital medicines usage data is shared as open data. And I'm happy to talk about the reasons behind that. We've got a paper hopefully coming on that in the BMJC. All of the model hospital data, and this is the flagship variation in care national analytics program, not a single one of the things that it measures about each hospital is shared. Now that would be much, much less disclosive. And I think it's really, really interesting to think, why is GP data always shared as open data, which then creates this really fertile ecosystem of people doing collaborative analytics to help, and also done in a really positive spirit. Like we almost never see anyone misusing open prescribing in a childish way. We never see people going, is this the worst GP in Kent? In fact, we've never seen that. But it's really interesting. GP data shared, hospital data not. And I do wonder if that's a function of their political weight and their size.
So we're rabbiting on, and what I'd like to do...
I've got to go. Yes.
Yeah, you've got to go. But let's finish on something positive. So we, myself and Mark, we're launching Open Data Saves Lives as a bit more of a thing this year. And exactly that point is to help people and give them permission to share more, do more, and also kill reports. So rather than writing reports and presentation of PowerPoints, build stuff that fixes stuff. So that's that's what ODI Leeds is doing. So in Kent, Mark, what are you doing that's sort of positive and out of all of this?
Well, I'm still reveling in my success with the police,
Yeah.
but I've also got I've got joint data control, which is a GDPR function, signed up across the whole region. So we've got 2 million people, 20 odd NHS organisations all signed up, no politics, really good network,
Amazing.
really good relationships. Everything we're doing is published openly. So that's really positive. And it looks like we've got some big research bids that we can announce soon to carry on building a linked data set at a lower level of depth than has been done, only akin to some of the stuff that Ben's doing. Most people are just linking sus data. It's not that interesting. So it's really exciting. We've got medical school opening. We're going to open a data lab with the university and the medical school. So I'm really excited about that.
Fantastic. How about you, Ben? What's next?
We're expanding Open Safely, and we're expanding it in various interesting directions. I'm really, really interested in seeing a better commons of knowledge around operational research. And this is something that me and Mark have talked about a lot. In fact, we've got a paper coming out in Journal of the Royal Society of Medicine, I think very, very soon, which is around how to kind of build, make operational research great again. The Lancet used to publish audits in the 80s. I mean, it was a normal thing. And now it's all done behind closed doors. And there are pockets of greatness and pockets of drudgery and manual labor in Excel. We need to make it a thing which has a commons of knowledge, a shelf full of textbooks and courses, rather than just go and sit next to Mark Farr for a while and you'll pick it up.
Well, my aim is that that's something that people who are 20 want to do when they come out of a university with a good maths degree. That's literally what I'm trying to do. So I'm going around university saying, this is cool. You can meet people like Ben and Paul.
Jesus, you're going to have to do better than that, man.
So on that bombshell, I'd like to say thanks very much. It's been amazing. And goodbye from Northernlands 2. Thank you, Ben. Thank you, Mark.
Thanks, Paul.
See you soon.